All right, Laura, are we ready to rock and roll, you think?
I think so.
All right, awesome sauce. Well, hello, everyone. Some familiar names, some new names. Welcome to the Collaborative Family Healthcare Association's Collaborative Care Special Interest Group, or SIG, as we call it for short. We are a very informal group that meets once a month to talk about all things related to collaborative care and intersection of things that interact with collaborative care. So feel free to eat your lunch, be on camera, be off camera, whatever you need to do to make sure you're taking care of yourself. I of course love to see your faces because I love to put names and faces together. But I get it if you're like, give me a moment in the land of Zoom. So welcome. Usually we have send out information the week before about what is coming up, but the holidays snuck up on us between summertime and this holiday that happened this week. So we did not get to send that information out in advance. So Laura has put the agenda in the chat for you. Today, we have kind of a little open discussion agenda for today, but I do want to remind everyone that the CFHA conference is coming up. In October, we will be in Raleigh, North Carolina. It is an amazing 3 days. Wait, is it three? Yes. I'll have to count. Like, wait a minute, it goes by so fast. Sometimes I wish it was four. Um, but the conference is coming up. And so during the conference, if you are coming to Raleigh, we will also be having our collaborative care SIG meeting like this in person. We have it during the conference. So we'll be there doing that, and there'll be some other things going on around collaborative care in addition to multiple sessions. Every year, I feel like it's more and more sessions related to collaborative care for people to dive into and see what others are doing and learn from each other. So hopefully you're joining us at the conference. If not, we will miss you this year. It's okay. We will hold space for you, and then we'll see you in November on the SIG call. That's how we'll work that out. That is really the main announcement, unless I'm missing something, Laura.
Just a couple call outs. So vote for the COCM awards if you haven't already. We will be also looking for elections. It sounds like those will be coming out in November.
Oh,
We're coordinating, kind of to determine how many openings are going to be. There's going to be at least one opening for chair. And for in terms of meetings, no virtual meeting for October. We're just going to have the in-person meeting at the conference. And in addition to the conference, we want to highlight some of the features that are going to be offered with the amazing COCM Summit. If you're not able to make the summit, then there will be also discussion at the in-person meeting of some of that content. Monica, anything to add to that? I know we had
so
we had
I was
quickly
supposed to
just finished.
highlight chairs. My apologies.
Oh,
You
good.
guys, this meeting does not work without people to make the wheels continue to turn. So we have three of us, myself, Monica Harrison, Laura Sadari, who you just heard speaking, and Ben Hilliard, who is not here today, who make up your leadership of the Collaborative Care SIG. But that is going to be changing, and we need some people who are willing to fill in and work together on this awesome team of three to continue this group going starting in January. Typically, we have individuals who stay on and those who roll. It's in a rotation, so there's always someone on who's been on for a while. We're in need of two people, actually. It's time for Laura to roll off. It was going to be Ben and I staying on, and then one new person coming on. But guess what, y'all? I got too many things on my plate. And so we need two people to come aboard as a chair to co-chair things with Ben and someone to come on as secretary. We walk you through the process. Again, the team of three, I think, works out great because when one of us is not available, there's always two other people. So it's never just on one person's shoulders. So please, please, please consider running for to be a part of the leadership for Collaborative Care SIG. So I was supposed to do that big punchline. Sorry, Laura.
That's okay. That's part of being a team. And just want to put in a plug. I've really enjoyed my time as COCM chair. It's a great opportunity to be able to meet others in integrated care from across the nation, those who are doing the work in the field, and then also those who are experts leading the charge for, policy change, revenue cycle, clinical, administrative. So it's a great opportunity to liaison and meet other individuals in the field. Even though it is a time commitment, I also want to put a plug in. It's not too bad of a time commitment. We have a leadership meeting once a month where we bring together ideas that are facilitated from our previous meetings, as well as what we see coming down the pipeline. And then are hosting meetings like Monica shared. It's really nice having 3 people that you're balancing that with. So it's been a real pleasure to be able to serve in this role, and I've learned so much. Also, don't be shy if you're new to COCM. It's whether you're seasoned or you're new, this is a great opportunity to get actively involved and has that spirit of CFHA where really there's an opportunity for a voice for everyone, whether you're early career or later in career. All right, let's get started with our agenda. These are some of the topics that have been coming up from outreach from individuals and also we're seeing in the news just this month. So for, myself as a psychiatrist, Psychiatric News just posted on our first agenda item, which we have here, Bill HR1, signed into law July 2025. So I wanted to start with an open discussion about what people know about that bill and what questions people have related to COCM, IBH, and mental health in general. Don't be shy. Do people know what that bill is?
The big ugly.
Yes. How are
So
people navigating
some,
that? Go ahead, Susan or Monica.
Yeah.
I was just gonna say, I saw some heads going like this when you said, "Do you know what that bill is?"
No, I don't know how much trouble it's going to bring us. I mean, I guess I hope it'll be beaten back, but maybe that's just overly optimistic. I don't know.
It does propose some changes. So I'm going to put into the chat, and these were like really nicely outlined in the Psychiatric News article. So some of the big things that are going to impact mental health, including but not limited to integrated behavioral health, primary care models, collaborative care, is going to be large cuts. And then there's also changes in Medicaid. And so this is something we're going to need to think about as we're talking about how to serve those Medicaid populations. There's going to be some increased administrative burden to think about. Some of the suggestions are to incorporate into workflows some of the requirements for verifying like working status for individuals. There are exclusions for people with mental health and substance use disorders causing a certain level of disability. So we'll want to also be taking a look at what are those thresholds and what can reasonably be accomplished in a primary care general medical environment versus needing specialty care. Other like kind of thoughts or questions people have coming up related to it. Like I've had a lot of questions I've had to engage with others on and also look up on my own. What questions do people have coming up?
I guess for me, I just worry that like the patients I take care of now in integrated care, like will they be able to come in a month or 6 months or a year if they're all of a sudden not on Medicaid? I work for a hospital system, so I don't call the shots on who we can see. We take Medicaid, but if all of a sudden this vast majority of people that we serve in integrated care no longer have Medicaid coverage, if these cuts come to pass, what happens to those people? How do I continue to serve them or prescribe their Suboxone or mental health meds, right? Or it's those kind of like, are we going to see an abrupt access problem that goes from bad to worse? That's kind of what comes up for me is like, what do we do if tomorrow they call and say like, well, I don't have Medicaid coverage anymore? Like, now what? It's scary.
Yeah, Jen, that was like with this article in particular, with the estimate of 10.9 million people becoming uninsured by 2034. That's really scary. I think it's important to point out also, so Medicaid, keep in mind, it's primarily state run, but supported by federal dollars. So we just want to be thinking about that as we're liaisoning and engaging our state leaders, as well as looking at the federal environment. Here were some of the kind of key pieces that were pointed out. So first, for this work exclusion, there's a work requirement that's been put in place for Medicaid beneficiaries 19 to 64 for at least 80 hours per month. These are people who are enrolled through the Affordable Care Act Medicaid expansion, and qualifying activities do include going to school. Exemptions are for the medically frail. So this is where we're going to want to think about for substance use disorders and other disabling mental health conditions. They would be exempt from this. What is that going to mean? What is going to be the documentation requirements and the burden for this? How should we be thinking about this for our Medicaid population, especially if teams like mine? I mean, we have half of the population that I work for clinically. Eric, are you able to come off mute and share a little bit?
Sure. I was just thinking, there's a lot of proposed cuts to behavioral health and SUD services overall, and some of them for sort of the most high needs individuals. That would certainly put more burden on collaborative care, but also collaborative care codes are new. If they're looking to slash things, perhaps some of the newer things that are ones to go. Just overall, it's concerning for behavioral health care and generally for Medicaid in general.
Absolutely. We've been making a lot of strides with collaborative care, but these newer initiatives sometimes get on the chopping block first.
Yes.
There's pros and cons with collaborative care kind of being on both sides of the house, physical health and having that overlap with mental health. Something that also stood out, so keep in mind taxes. So states usually cover their portion of Medicaid using funding streams like taxes on providers. There are going to be new ceilings for this. So 6% revenue for treating patients in states that have expanded Medicaid, and they're going to be decreasing that threshold for provider taxes. This holds pros and cons. How are we going to fund this? But also, is there kind of a benefit of reducing that tax? The other thing that was pointed out in this article from Psychiatric News was related to state-directed payments. So in terms of these ceilings, in the beginning of 2028, state-directed payments will decrease by 10% each year until they reach 100% of Medicare rates. So we've been having higher than Medicare rates for a lot of our Medicaid. Now there's these efforts to reduce that. There is going to be a cost sharing and copay unless people have one of those exemptions. And so this is where kind of considering this as part of our workflows and part of information. Thoughts or questions about that? Shonda, can you come off mute? Share a little bit of what you think.
Hi, just putting one probably everyone already knows, which is it's a cost saving move, which and great, let's save money. But unfortunately, when you work in healthcare, right, it's like saving money by cutting services just means people will show up sicker and worse off when they show up. So we're not actually probably in the long run saving any money. We're just being cruel to people.
Absolutely. We got Michael Uhas on the call here. I know Bowman Family Foundation published a great article, great information about how collaborative care saves money. And ultimately, it's not by the services themselves, it's those downstream costs of reducing hospitalizations, reducing ER visits. So it's sort of that penny smart, pound foolish approach. This is not something like I can remember a lot of us on this call were talking about not wanting this to go through. In fact, CFHA, I see Jen, we facilitated submitting a counter argument about why we should not cut Medicaid, why this is important to maintain, using, a variety of different data, including provider voices, member voices, as well as hard, kind of like specific quantitative data. So this is not something that we want coming. It makes it hard to know exactly what to do in these situations. hopefully this information gives us some empowerment for what to do with it, but really want to acknowledge that part, that this is not something that most, if not all of us probably on this call wanted. Thanks, Shonda. Other perspectives.
I don't understand about the state provider taxes and state directed payments. It looks like it should make sense, but I apparently am not aware that this is even happening, so I'm not sure I understand the change either. Sorry.
This was surprising to me also, Chanel. So, again, like this is just, if you've got Psychiatric News, their September article fresh off the press helped to outline some of this. I was not aware of it either. And that was why I wanted to bring it to this space. My read on this, and please, like others, correct me, if you've got different impressions. The state directed payments, like basically one of the ways that we've been able to help reinforce Medicaid and like kind of having people take that is by going above those Medicare rates for reimbursement. There's going to be a push to reduce, instead of saying like we're reimbursing at 110, 120% of Medicare, reducing down to the same. The provider taxes, I didn't even know kind of that was a thing. But my understanding is they're going to be cutting these sort of ceilings for these revenues for treating patients as a cost savings measure, but where are we then going to get that money further? So that was kind of my question that came up with that. How are we going to fill this gap? The states, so keep in mind Medicaid, state funded, supplemented by that federal funding. So these were points that surprised me too. And I don't know exactly what these are going to mean either. Other perspectives or questions? In terms of increases, there was a Medicare physician payment bump of 2.5%. However, there's also a student loan cap on federal loans. So this was like the total amount if you were to do undergraduate, medical school, all the above, like that would be the max amount. Many of us, on this call who've done medical training, that would not cover a lot.
So unless you go to a funded position for your doctorate in psychology, it might not cover it either.
Yes, absolutely. So doctorate degrees. So this is like master's, undergraduate, and like doctorate level. Yeah.
I mean, it's just going to cut out people without means, right?
Increases disparities even more. Those were the big ones that were highlighted. Are there other from the bill? Are there others that people have noticed to bring to, awareness? A big part of what I've been trying to do is just understand and educate myself on what this is going to mean and start to think about, as a program director, as well as a clinician, how we're going to maybe need to structure workflows. One of the main recommendations made in this article was thinking about, as part of like your documentation and process workflows, how to incorporate this. So for instance, with the exclusions for work requirements and for other things for people with severe SUD and serious mental illness, that might be a consideration in the primary care environment to think about. There weren't a lot of other recommendations though. So other perspectives here.
Well, I think one of the barriers that I've run into with collaborative care model in general, and I think moving forward with the reduction in Medicaid and everything that's going on with HHS and the CDC, just like requiring prescription for COVID shot, that's like more work on the PCPs. That's less work, collaborative care model inherently puts more work on a PCP. They have to prescribe the medications. They have to see the patients. That's like one more problem. And the problem list that they're responsible for. And I think it is very efficient, but you need robust PCP, engagement and support, and they have to have the bandwidth for it. And so I think, you know, now when you have uninsured patients, you have, you know, more of everything, more burden on the social determinants of health. Plus, you're arguing with people about vaccinations. Plus, you're having to write a prescription for every person that wants to get their COVID vaccination. That's, you know, I mean, I don't really have any solutions for any of this, but it's just important to be aware. It's like, yeah, well, you can add all the codes you want, but if you don't have, you know, PCPs and you don't have nurses and you don't have MAs because they've, you know, quit or just are overloaded to do the work, then the whole thing fails. And so I think, you know, we just kind of keep on advocating and not forget that, yeah, like pushing back on things like this requirement for prescription is it's such a pointless, ridiculous burden on PCPs.
Yeah, is that live now? Like, I'm a
Oh
PCP.
yeah.
I'd have to write a script for every patient of mine that wants a COVID shot, not just go to your local Walgreens or health department and get it because we know it's evidence-based. It's now you got to do that jump through the hoop of get a script from your PCP. That's
Depending on
I
the
don't think
state,
that-
I
yes.
think it depends on the state, but in Oregon you do, which is great. You know, like Oregon is not a
Yep.
I thought that wasn't
Wisconsin,
real. I mean, like, I thought that we were sort of preemptively planning for it, but the conversation I saw yesterday, they said the law actually hasn't passed and everyone's essentially complying in advance by writing all
they
these.
are. Well, I have
It's
an
also
appointment for a
problematic.
COVID shot tomorrow, and they're telling me I need a prescription at Walgreens.
wow.
So.
Wow.
Wild.
It's chaos. I feel like it's reminiscent
Exactly.
of I don't know, I'll just share my point of view of, you know, 2020 when we had a chaotic the political environment made it harder as a healthcare provider to access evidence-based recommendations, to follow guidance. And I guess I'm just hoping that we can get through these few years and get, I don't know, back to whatever normal would be. But it feels reminiscent of that chaos time where we're just scrambling to figure out what's best, and having these political overtones limit our ability to care for our patients. So it's like a hard to harder, and it sucks. It's not fun. So
well, I agree. It totally feels like COVID all over again, right? And it's hard because some of these things in the bill, like purposely don't go into effect for a couple of years. So I feel like there's also all this uncertainty, right? Of like, well, what should we be doing? Should we be doing now? Do we wait? Are people gonna have Medicare this fall? Like, I don't know. Or Medicaid rather, like this fall, right? Like, it's just, and no one has any answers because I think unfortunately part of the MO is to create the chaos. Like there is no answers. People don't want to give directions.
yeah.
That's a huge, huge point. That is one of the things I liked about this article, that it gave specific dates for some of the highest impact things that will impact mental and behavioral health. But yes, that's another burden, right? And then who's curating that information? Somebody had to go through all that information. What's the burden of that compared to other articles that could be written by the APA? The other one that I wanted to point out is also immigration status was another one. So coverage of undocumented immigrants. Currently, if states cannot verify an applicant's immigration status in real time, they're required to provide Medicaid benefits for a reasonable opportunity period. In October 2026, that requirement will be eliminated. So states can then elect to provide coverage, but only can use federal funds if the immigration status has been verified before end of the period. I mean, it's just more layers. Liz, are you able to come off and share a little bit of the perspectives you added in the chat?
Sure. I think the example of undocumented immigrants just also emphasizes the importance of primary care teams kind of understanding the different landscape and roles that clinicians, you know, may find themselves taking on, navigating those social needs and insurance coverage, enrollment assistance. Our state in Montana certainly lacks the administrative capacity at Medicaid to even oversee all of this. So, I mean, we're just trying to think about the other levers that we can use to help advocate for patients to, you know, file appeals and work with our legal services associations to ensure that our state is complying with the requirements, even though they don't have the administrative capacity to oversee it. I don't know. Yeah.
It'll be more important now more than ever to have the shared, group think in these sort of spaces. So I think learning and leaning on one another for what we're doing in our different areas, what we're seeing can help. That was helpful in COVID, leaning on others for like how you were navigating things in your area, continuing to advocate for change. So keep in mind Medicaid, state related, big component there too. So we're planning, Monica, Ben and I were planning to have some state speakers come in December to be able to share some perspectives, what's going on in different landscapes, people in different levels of uptake and kind of establishment of CoCM codes. There are opportunities to influence in that way as well, but it is very challenging and it is concerning. Thank you so much, Bethany, for putting that in the chat so you can find the article, What Does the Massive Reconciliation Bill Mean for Mental Health? That's the article that I'm referencing. And I'm going to keep it as a reference and as a resource. I would encourage others to also, because it gives nice dates, it gives some kind of high impact pertinent pieces for us to be tracking on. Other thoughts or questions related to this before we go on to the next topic, which is some of the changes for coding that are coming down the pipeline for 2026?
I just want to highlight one of the, reasons why I was so glad that Laura was going to be bringing this information is for us to know and be aware, right? So we hear just from this conversation in some of our states and systems, they're preparing now. So they're putting rules and things in place now for preparation, even if it maybe hasn't gone into effect. And in other places, we had no idea it was even happening or possibly coming. So I think just that importance of having conversation in your system in the event that you do need to pivot. What would that look like? How are those individuals going to be served? Because they're still coming. As I think Shanda said it earlier, like they're still coming. And so how will they be served? What is that going to look like? Are we going to need to turn people away? Just some of those things to start to prepare as much as possible.
Thanks so much, Monica. That's a key take home here. We don't like it, but we do need to prepare and know what we're going to do about it for our patients and for our care systems. The next topic for discussion is some of our 2026 CMS proposed codes, and there's some that overlap with CoCM. I'm going to put one reference in the chat. There's several others. What I like about this one from the AMA is it's got some outline of impacts related to medical providers, which overlaps with some of the highlights that we're going to point out related to CoCM. Some of the big CoCM impacts are expansion of add-on codes related to new G codes that would eliminate the time requirement for CoCM. These are called let me find these. Where did they go? They're like advanced primary care management services, APCM. And I'm still familiarizing myself related to these. So don't feel bad if you're not as aware of it. I'm learning right along with you guys. For this is an element-based approach for BHI. You have to have 13 different elements, and it overlaps with fidelity to a lot of the requirements for a collaborative care model without the need for minutes. It is done based upon complexity of the medical conditions, the total health conditions. So based upon the number of health conditions, that is how you would code. This might be of greater advantage for teams that are having difficulty with the administrative burdens of tracking on time, difficulties being able to make sure that we're keeping up with this. This may not be as advantageous for patients that are needing multiple add-on codes and lots of time. So I think back, we had a presenter a little bit over a year ago with oncology in CoCM, very small, number of caseloads, like 30, because we have lots of minutes, lots of care needs. This may not be as advantageous for that kind of population. but could be an opportunity for individuals who, are not tracking on time or having difficulty with that. Yes. So Sarah, do you want to come off mute and share a little bit? To be clear, the change in time tracking would only apply to APCM. Do you want to share a little bit?
Yeah, this was one of my concerns when I read the proposed rule changes. The message should not be that these changes remove the requirement to track minutes in collaborative care. That would only be true under these proposed changes if your practice is providing APCM services for those patients. So just want to be really clear that it would not apply to COCM overall.
It's if you're doing add-on codes to capture COCM work with APCM. Is that correct, Sarah, or do you have a different understanding?
Honestly, this is not my area. So I would encourage folks to check out the links that you put in the chat. But it's basically if you're providing advanced primary care management services and you also want to provide collaborative care to those patients you're providing APCM to, then you wouldn't have to track minutes.
Yes, that's my
A
understanding as well.
subset. Yeah, it's a
Add-on.
subset of patients. Yeah.
And you cannot charge for both. So you cannot do COCM and these APCM add-on codes. Other perspectives, is anybody looking at these for their health system? I mean, right now, at least just for my team, we are not looking to incorporate these or make changes because we're not doing the APCM codes to begin with. But, what are other people's perspectives or thoughts?
So my system, we do code TCM, transitional care management, and CCM, chronic care management, for a subset of our adult primary care patients. These are largely Medicare patients that have had hospital follow-ups or maybe, numerous chronic high-risk medical conditions. Anecdotally, there's not much overlap in my patient population between those folks and my COCM. My COCM tend to skew younger and Medicaid. Not that you couldn't benefit from COCM if you're, 70 with Medicare and have heart failure and, insulin dependent diabetes and severe depression. You could, but so yeah, I guess that's an interesting point that you couldn't bill for both. If we had someone that's getting CCM, we couldn't also chronic care management. That entails an ACO care coordinator. So what that looks like, if you're not familiar, is we have a nurse who's employed that calls and checks in with that patient, ensures that they have follow-up with their specialist. Say, you're admitted for heart failure. Let's make sure, Nurse Jen calls and says, hey, are you going to see Dr. Smith tomorrow for your heart failure outpatient follow-up? Are you taking the diuretic we started you on in the hospital? And did you increase the dose as we recommended to keep you out of getting readmitted for heart failure tomorrow or next week? So that's kind of what nuts and bolts, not all they do, but a big piece of chronic care management is a lot of that networking and hand holding and follow up that, is not unlike a little bit of what we do for behavioral health with COCM. But so I guess I'm understanding you right. It's like those folks that are actively receiving chronic care management couldn't also in the same month get COCM. It wouldn't be billable. Am I understanding that right? I'm not a biller. Oh my God.
So it's
Okay.
APCM, not CCM.
Okay.
So Bethany put in the chat, we're billing both CCM and COCM codes. Yes, you can for both.
You can. Okay. You
but
can.
This is APCM. So this would not, my understanding, Bethany, this would not change or prevent that. This would be another coding option if you are doing APCM.
Okay. Anyone doing that? I'm curious. What is that? I'm not familiar with that.
So I'm still learning about it as well. The advanced primary care management CMS link that I put in, I thought had some helpful information. So APCM services combine elements for several existing care management and communication technology-based services you may already have been billing for your patient. So here's kind of the different components. And it allows you to provide patients with a wide range of services to meet their individual needs based on complexity, and build for these services using a monthly bundle instead of billing for individual service. My understanding is these APCM codes came out in 2025. My team has not been using them. these add-on codes offer opportunities for expansion of like kind of BHI under the umbrella of these as an add-on code, is my understanding. So, you know, I'm exploring these with my healthcare system, but I also, this is new to me. This is new information. Is anybody on this call using APCM codes? And if so, how are they kind of using that for their care population? Yeah, this is something to explore. If anybody has any follow-up information, go ahead and put it in the Basecamp chat. You know, I'm very interested. This is an area that we're taking a close look at with this expansion. One of the things I found helpful with the 2026 Medicare physician payment schedule from the AMA is it broke down some of like the considerations for how that may impact like on the medical side looking at this. The other codes that I thought were helpful to highlight is changes in the FQHC, RHC coding, getting rid of the G codes and adopting the CoCM codes. Monica, do you have any additional information about that and kind of those changes?
Yes, only only that people feel very mixed about it. There are a lot of FQHCs who are providing collaborative care services, but are not necessarily billing the collaborative care codes because they get better reimbursement when they use their FQHC rate. So there are those individuals, which your rate varies from FQHC to FQHC. It could be the same FQHC in joining towns, because there's not more than one in a city, but joining towns, and we can have very different base rates. Some individuals are not liking this proposed rule, while others feel like it would be very helpful just to be on the same page with collaborative care and being able to utilize the codes in the same manner. But others feel like they would actually get lower reimbursement and would rather not. So it's very mixed reviews from those who are in the FQHC world about advocating for this change or not.
Excellent summary. Any FQHC perspectives? Yeah, so Liz, these are proposed for 2026. These changes to the CoCM codes.
And I'm not sure if they had asked for comments so people could submit comments, but I feel like the deadline passed. I feel like the deadline was last week, if I'm not mistaken.
The CMS, it's the 12th
Of September. Okay, so you
September.
still got time. So you
Yes.
still got time, you know, for comment. You know, I've heard some individuals say, like, what's the point? They don't really read the comments. They actually do. Read the comments, and when there are a lot of people saying similar things, not the same thing, because actually if it is the exact same language, it kind of gets shifted out and just made into one, versus if there are people with the same sentiments but different language, that is taken into consideration. So I encourage individuals, if you have a stance one way or the other, to submit comment. They are read, they are considered. You would be surprised, even things that were proposed years ago, that it's coming back up and has come through years later. So also don't feel as though I made these comments, tons of people made these comments and they did not listen, they still did da da da. Sometimes things come back later on down the pipeline. We were actually just having this conversation a little earlier about even other things that aren't about these proposed rules, like trying to make collaborative care a preventative service, things like that. At the AIM Center, when we send our comments in, we are oftentimes also including other recommendations that we have included in the past until it sticks. So we encourage individuals to please submit your thoughts and your comments to the proposed rules.
And Kim, you know, I think that's a great point in here, you know, also looking at engagement with different organizations. I can say, at least on the Arkansas side, there's been some good success engaging with FQHCs in collaboration with psychiatrists, as well as just in general CoCM around the integrated care pediatric SAMHSA bill. So when there's like a reason to collaborate and kind of join forces, I think that really helps. But yeah, it's challenging. What are some of your perspectives and some of your thoughts related to that conversation for you, Kim?
Well, Arkansas had a little CFHA magic involved, that they had a particular champion, you know, and the connection with that, you know, the brand new group out of Chicago that was doing this, you know, so there was definitely, you know, I think that's a lot of it is just you know, kind of it feels like you sort of, yeah, you have to have these, you know, particular champions moving it forward. And then, you know, so I'm on the West Coast, I'm in Oregon, and then I've also tried to get some projects going in California. California is so tough. And they do, I mean, California does have the advantage that they have the they do have a network that's really working on this. So you know, they're running into barriers, but at least they're sort of identifying what they are and just trying to find some kind of path forward. So they do have a dedicated group for that. Cal Peer Network, I think it's called. They're connected to CFHA if anybody needs that. But and then in Oregon, we have our, you know, funky CCO system. And they, you know, when it was set up to integrate, you know, it was really set up to integrate behavioral health, but it was done so from a very PCBH model focus. And some of that was the nihilism about, you know, well, you can't get psychiatrists and you can't get, I mean, some of it had to do with who was pushing, you know, who was in charge, and they were a PCBH model person, but some of their sort of argument was like, oh, you can't get psychiatrists. And, you know, I happen to know, like myself and, you know, that there are definitely psychiatrists in Oregon that are, you know, ready and willing to participate, but it's also just like, yeah, again, it's like that connecting those dots of, you know, I mean, I'm like, I can see into the FQHC next door, you know, I'm looking through their windows. You know, I know them all, I've known them for years. We've tried to get it going so many times, but the payment, you know, figuring out the finance is so challenging. And so it's like the PCPs want it, I want it, we love each other, we want to work together. And yeah, it's like, you know, kind of convincing, you know, someone with a C at the beginning of their title or a VP or whatever is always just sort of like that. No, we can't do it now. We don't have the scope of practice. We don't have the, you know, there's always some kind of complexity that the FQHC is just like, this isn't a good time, or it's not the right time, or we just can't do it. We can't make the numbers work. You're too expensive. At one point, they were going to recruit a PMHNP, or they did recruit a PMHNP because psychiatrist was too expensive. And, you know, the PMHNP ended up bailing on the whole thing because they were like, this is over my head, you know, wisely figured out that this was not a good first job right out of PMHNP school. So, you know, kudos to them for recognizing that. But yeah, so that's kind of some of the barriers we've run into. And it, you know, I had this conversation with them. It's like, yeah, you know, psychiatrists with 20 years experience, you can hire for half the time versus someone just out of school who's having to kind of figure everything out from scratch. So it's like, okay, even if I were twice as expensive, it's still, you know, there's still that value. But again, it's, you know, there's the clinicians who get it, and then you get a couple layers up, and then there's someone like losing their mind over a you know, an hourly rate. So, and conflating a PMHNP with a psychiatrist, and we're not the same, you know, as much as I love my PMHNPs.
A lot of barriers. And, you know, sometimes even if like a change like this, we're talking about the change in the codes, maybe it's an opportunity for a conversation. Investing in that process of building relationships, you know, like you shared with some of the areas of success, leveraging relationships can be very helpful. So that's where individuals like myself and others in this group, we're here behind you and here to support being able to build and leverage those relationships. So if there's any opportunities like that for extra support, let us know. This is where, like Monica shared, it's yet to be determined how helpful versus not these code changes could be. But if it were to give an opportunity to have a conversation, that can be helpful. Michael, go ahead and come off mute. Share your thoughts and questions.
Find out how to do that. So my question is on the FQHC. We have talked to a number of people trying to, in the spirit of trying to get more collaborative care delivered through FQHCs. And the first response we get is very often, they're not going to bother. They're doing fine with the PPS system. In line, I think, with what Monica was saying a few minutes ago, just sort of getting them even interested. But Monica, you made an interesting point about them doing it. They're delivering collaborative care, but they're using the PPS to do that. And we've heard conflicting information about that. I'm just looking for someone who can walk me through maybe examples of FQHCs who are actually doing this. What we don't want to be fighting a battle that's not going to go anywhere. And if we're looking at the wrong issues to be trying to influence, we want to know that. So my question is really, is anyone on this call, or could you point me to someone who understands this deeply enough who can give me examples from FQHC?
Anybody on this call who can
I was
share?
going to say, I'll let
Go
my
ahead.
FQHC friends go first.
I don't know who the FQHC folks are, so speak out.
I was trying to look and see.
You know who comes to mind is Beth Ziegler-Schreider at Access.
I know. I don't see anyone else on here. Well, Michael, I can tell you from my time in working at the FQHC and then now on the consulting side, working with FQHCs, what happens is they use their PPS for all of the face-to-face interaction, and they will probably have more face-to-face interaction than what maybe some of my other colleagues on the call who are doing collaborative care and have behavioral health care managers that are doing a lot of phone contacts and things of that nature. At the FQHCs, what they'll do is they'll schedule more face-to-face things, and those face-to-face encounters you can then use your PPS for. So then what happens is any of the things like talking with the psychiatric consultant to do systematic caseload review, you can't use your PPS for, and that is a collaborative care thing you need to do, but their PPS is so good that it doesn't matter. Like they can eat that cost. It doesn't matter.
So they're paying essentially a clinician to be able to deliver care, to provide care, and the rate of reimbursement of the PPS is good enough that will more than cover the additional time they're not going to get paid for with the consult, with the site consult, you're saying?
Correct.
And my understanding is that there's a minimum of, you have to spend at least so many minutes before you get that PPS. But for the sake of this discussion, if that minimum were 15 minutes, but you could get paid that same rate as if you spent 45 minutes. And again, I'm basing this on my limited understanding. Why wouldn't I've raised this issue with others? Why wouldn't you just hire that clinician and have them see everybody who's getting the CoCM service once a month, twice a month, whatever the allowable time frame is. And I haven't been able to find anybody who's told me, yeah, that's just what we're doing. But it sounds like what you're describing. So I keep getting confuser on this. The more I hear about it. So
somebody who's been really helpful in this front is Verna Little. So I would encourage reaching out to her. Maybe we could have Verna.
With Verna, I know Linda. I keep going. I know Verna, and I connect with her regularly. I've asked her to actually speak with a couple of the FQHCs she worked with. I haven't yet been able to connect with one. But thank you. That is good guidance.
Yeah, she had some perspectives to share, because I had kind of asked her when a lot of this information I got originally from her related to what I'm putting in the chat. So I think it would be helpful to have her perspectives, and feel free to put in the Basecamp any kind of key things that you find, because I think this is an area a lot of people are grappling with. There's pros and cons with uptake, sustainability with this change. And I think that'll be helpful for us to know heading into 2026.
Yeah, the other council we've gotten has been sort of just steer clear of it because the FQHCs are not unhappy with what's going on. They don't want to be put in the spotlight for other things. So we're just trying to navigate this again, not spinning wheels, but trying to figure out what can we
Yeah,
do that would be
I mean, I
helpful.
think Michael, what you're running into is what I've heard. The FQHCs, for the most part, like the way it's working for them because their reimbursements are really good.
Yeah.
And so, like, don't draw attention over here where stuff gets changed for us.
Yeah.
Is kind of the premise that I've heard from a bunch of individuals who do work in FQHC world. And like I said, they're doing the collaborative care, the stuff that is face to face of that. They're charging their PPS, they're getting what they need, and they're still. And the truth of the matter is, in the FQHC world, you're oftentimes doing that stuff anyways without getting paid, right? Like they're just kind of used to that. But many of them have done their spreadsheets and done their cost analysis and all of that to find that, yeah, it's completely fine for us to continue to do business the way that we've been doing business. And yes, we'll do the systematic caseload review and some of those things that we can't bill our PPS for, but still come out. So that's where, like, depending on who you talk to, like you talk to
Yeah.
Verna and she could say like, hey, yeah, we should do this and here's why we should do this. You talk to someone else and they go, well, wait, no, we don't want to do this because this is working fine for us, right? So I think it just depends on the perspective
Yeah.
of the person who you're talking to.
All right. Well, I don't want to take time away from the meeting anymore, but thank you for that. That was very helpful. It helped confirm what I think I already knew, but I'm still left with a few clouds. But thank you.
No, this is how we learn. Excellent discussion. Would it be fair to say that maybe this is favoring people who've not had uptake of COCM compared to those who have, Monica, or is that too broad of a statement?
Say it one more time.
For FQHCs, would this change favor, those who have not invested in or considered uptake of COCM at the detriment to those who have been doing COCM under the previous model?
I could see that. I could see those who have maybe been hesitant to even try it being willing to give it a go. But then
Great
it would change
conversation.
things for everyone else, right? So
Yeah.
yeah,
More of a
Yeah,
fee for
thank you
service
for that
approach.
reference, Jen.
yeah.
Thanks, everybody. What a great conversation. This is difficult stuff to sort through. This is the part of our job that I would say is not the easiest. So thanks everybody for perspectives, great discussion. Feel free to add any follow-ups into the Basecamp messages of things that you find or other questions you have for follow-up. And we hope to see people in person next month at the in-person meeting.
Wow.
All right, everybody. Bye.